All right, good morning, everyone. Welcome to the second live quiz transmission from the first affiliated hospital of Harvey Medical University. My name is Lesion. I'm the moderator, and the first operator is Dr. Gong Yongcai, and the rest operators are Dr. Zhao Jiyi, Dr. Sun Danghui, and Dr. Li Tiankai, and Dr. Wang Dingyu. And today is the IVL day. I think our enemy is the calcification. So first, Dr. Zhao will introduce the case.
Good morning, everyone. I'm Zhao Ji. Before the operation leaving broadcast, I would like to make a brief introduction about my patient first. This patient is a 63-year-old male whose chief complaint is paroxysmal dyspnea for 3 months. The main risk factor of his
Next slide.
is smoking and hypertension. His echocardiogram showed an ejection fraction of 70% with no
Next slide.
marginal abnormal mellitus. Next, the electrocardiogram showed sinus rhythm and no T wave inverted and ST segment depression. Next, the coronary angiography showed that there was a serious stenosis in the proximal LED with severe calcification. Next, there was a moderate stenosis in the ostium of the first diagonal branch. Next, we also found nearly 15% stenosis exists in the middle segment of the LCS and RCA with severe calcification. Next. Before the operation, we conduct a QFR examination on the patient. The QFR of LED was 0.64. Virtual standing technique simulates the effect of the stand explantation in selected segments using predict value of the QFR. By using a QFR-based virtual standing technique, the QFR of LED may be increased from 0.64 to 0.95. It could help us to make a plan before the operation. Next. And then we have performed a CTA scan on the patient, and the results showed that there was a severe stenosis with severe calcification in the proximal LED. In order to understand the coronary artery lesion deeply, the intelligent visualization system for CTA invented by Professor Li Yue in our hospital would help us to get more information. Next, please Professor Wang Dingyu introduce this part.
Yeah, here's the intelligence visualization of the coronary 3D reconstruction. I think Dr. Wang Dingyu will introduce this image.
Thank you, Dr. Zhao and Dr. Li.
Dr. Wang, are you ready?
I'll show the intelligent visualization system for coronary.
Dr. Wang, we couldn't hear you.
Okay.
You had to turn on your speaker. We couldn't hear Dr. Wang talking. So this is the image from the intelligence.
Okay.
Yeah, I can hear you. Okay.
Now I'll show the intelligent visualization system for coronary CT angiography. We have shown this system for many times, and just like the audience online asking the previous case.
Sorry, Dr. Wang, your sound is not very clear. It's very blurring. There's the echo. When I talk, I can hear the echo. But that's okay. I think I can do the explanation.
Okay, can you hear me now?
Yeah, I think now it's fine.
Okay. Okay, now I'll continue the introduction. Just like the audience online just asked in the previous case by Professor Li Yue, we think the unique technique that the intelligent visualization system for coronary CT angiography will be a useful method or weapon for the complex PCI. Now we have the ELTA, the calcified plaque in ELTA, and we can see this is a really severe calcification lesions in both the right coronary artery and the left coronary artery, but the lumen in the right coronary artery is enough now, and we have the right coronary artery and its plaque enlarge the left coronary artery, and also we can see there's heavy severe calcification in circ, but if we hide the calcified plaque in circ, now we can see the lumen of circ is enough. So I think we should not do PCA or stent in the circ. Now let's hide the circ and just pay attention to the calcification in LAD. This is the EP position, and we rotate the image, and in the AP crenal, we can see the calcified plaque is from the ostium of LAD to the mid part of the LAD, and we rotate the LAD image, and we can see there's severe calcification in the LAD. In some in some segments is about almost 270 degree. This is really a severe calcification lesion. That's all. Thank you.
All right, thank you so much, Dr. Wang. I think the 3D reconstruction of the coronary artery is super important. So from this image, we could see the patient has a lot of calcification, especially in LED, and in the most severely part, I think the angle is over 270 degrees. So Dr. Gong, for this severely calcified lesion, share with us your plan.
Okay. For the severe calcification lesion, as we know, the most important factor for the successful procedure is the pre-treatment strategy. So the intravascular imaging is very important for selecting the optimal pre-treatment strategy. For this patient, we try to perform intravascular imaging firstly, but unfortunately, the IVAS guide the IVAS catheter cannot be cross the lesion. So we choose a rotational activity to modify the calcification. Then performed intravascular imaging, and next we performed intravascular lithotripsy. Now, after the fully pre-treatment with teaching and IVL, we now perform the intravascular imaging again to evaluate the result of our pre-treatment, and next under the guiding of the intravascular imaging, we will finish the stent implementation.
Yeah. So actually, we started this procedure much earlier. So at the very beginning, we tried to deliver the avus catheter through the lesion, but it was it was very tight. We couldn't deliver the avus catheter through the lesion. That's why you thought of the use of rotational atherectomy. So can you show us the process of the RA?
Okay, this is the procedure. We select 1.5 millimeter uh, r- r- burr, and then the rotation of the rectum was successfully completed. And after rotation RA, the intravascular uh, ultrasound catheter can be successfully delivered to the distal of the lesion and complete the first intravascular imaging.
Mhm. So please show us the avus image after the use of rotational atherectomy.
Okay.
Can you show us the avus image after the use of RA?
Yeah, okay. Okay, this is a Chinese original ALA system by Insight Life Tech. So we can see there's a Chinese Windows that we can use it easily for our Chinese operator. And now we'll show the pullback. Okay, this is the distal part of the Lesion. And we can see the myocardial bridge in the distal part. And now we can see the calcified plaque in the superficial part of the plaque. And this is okay, in the we can see there's a heavy calcification is almost 300 degree. We can see there's some fracture in the superficial of the calcification. The RA is a useful method for these lesions. Now there's now we can see the left man is healthy, and I want to ask Dr. Gong, do you want to have a provisional strategy or accurate position? And the whole layer length is 63 millimeter. That's all. Thank you.
Okay. Thank you, Professor Wang. After the first intravascular imaging, and we performed IVL. This is the IVL balloon. We select a 3.5 millimeter IVL balloon, modified the calcification lesion thing, and after the IVL, we performed next, we will show the imaging result after.
Let's show the hours. Okay, this is the hours image after the IVL, and this we have seen there's some fracture after the rotation. Now we can see the effect of IVL. Okay, there's a bigger fracture after the IVL compared with the fracture after the rotation. And there are several fractures we can see. And in the proximal part, there's Also some fracture of the calcification plaque.
Okay.
Okay, now it's the left limb. That's all.
Okay, thank you. Based on the finding of the imaging, next we will perform stent implantation, and according to the finding of the imaging, we will implant two stents from the middle segment of LAD to the left main. Okay, the first stent. Yeah.
So after the AVA strong, do you think the pre preparation is good enough for the stenting?
Yes. And the AVA showing, and we can several fracture of the calcification, and also we will perform pre-dilation with NC balloon. Just now we finished the NC balloon pre-dilation with 3.0. For the proximal segment, we will use 3.5 NC balloon to get full pre-dilation and a good pre-treatment result.
So for this patient, actually the pre-treatment involves the combination of different techniques. So the rotational atherectomy first, and then after that is the IVL and the NC post-dilatation. So after all those techniques, I think we have created enough room. Now I think it's the good time to put the stents. So for the stenting, because the lesion is kind of diffused, I think there's no good spot to land the stents at the proximal LAD. That's why you want to cross circumflex, right? Two stents,
yeah,
and the second stent has to cross the circumflex.
Yes, the second stent will cross over, and because of the after of the LID, it are not good landing zone. So we decided to perform a crossover strategy.
When Dutch John introduced the case, we did the QFR, we did the virtual stenting. So the virtual stenting give you some general idea like how to put the stents. Do you think the virtual stenting is very useful?
Yes. For the patient after the virtual stenting, we can see the QFR will increase to 0.9, and the virtual stent will help us to choose the perfect stent landing zone for the proximal and the distal. I think it's a very useful technique.
Because the virtual stenting can give us a lot of guidance, like where and how to put the stents. And also after stenting, according to the virtual stenting, we know there will be a huge increase in terms of the QFR. So now I see you put it where in the first diagonal for the protection already.
Okay, just after the pre-dilation thing, we will perform the first stent implantation.
So what's the size of the first stent?
In fact, the size of the NC balloon, is 3.5. And next, because the distal landing zone will cross the distal diagonal, and the lumen will get smaller. So we choose the 3.0 millimeter as the first stent. Okay, the first stent.
So there's a kind of difference between the middle parts of RD and the proximal parts, the distal part of RD. That's why the first stent is kind of small.
We are
Dr. Lee, Dr. Lee, can you hear me?
Yeah, I can hear you.
Okay. The topic today is IVL. So,
Okay.
Professor Li Yue and Professor Gong show us two cases of rotatripsy. Now, in the past years, we know when we treat the calcification lesion, we have only the rota in China and some scoring balloon or cutting balloon. As we all know, Professor Gong is a high volume rota operator. Now, but today, Professor Gong chose the rotatripsy strategy. Why do you choose this strategy, Professor Gong?
Okay.
Why do you choose rotatripsy, but not the rota alone or least or the IVL alone?
Okay, no, because for this patient, the stenosis is very severe, and firstly, the IVAS catheter cannot be delivered, and this petition, I think the IVL balloon also could not cross the lesion, so we performed firstly to dilatation the lumen and in order to get the easily delivery of the IVL balloon and cross the significant stenosis portion of the lesion.
Yeah. So right now we have more weapons to fight against calcification. If we do not have the IVL, maybe after the use of rotational atherectomy, we can use some balloon-based technologies to treat the lesion. I think it should be fine. But right now we have better techniques. Why not use it, right? That's why I think you choose the rota and lithotripsy strategy. This is a very good choice.
Yes, just like Dr. Gong said, we have so many weapons, and in the recent years, we have many articles tell us about the methods against calcification. There are some very, very complex algorithms tell us how to when we will use rota, when will we use IVL. But I have just read an article this year, which published in the cardiovascular intervention therapy. It's a very easy algorithm, just like Dr. Gong said. When we can deliver an imaging catheter pass through the lesion, if we can deliver it pass through the lesion, then we can choose IVL as the first choice. But if we cannot deliver the catheter to the distal part of the lesion, we will choose rota. And just like some articles tell us, if we choose rotatripsy strategy, we can choose a smaller RA burr. In some statement, the experts told us we should choose a RA burr. The ratio of the RA burr to the artery should be 0.6 to 0.8. But just like some articles tell us, if we choose the rotatripsy strategy as the first choice, we can choose a rota burr. The rota burr to the artery can be 0.5 4 to 0.5. It's much safe for the operator and for the patient.
Yeah, you're right. I think nowadays there's a transmission in terms of the treatment, the pre-treatments of calcification. Before I think we took the debarking strategy. That's why the ratio should be bigger, maybe 0.6 to 0.8. But right now the idea has been changed to the modification. So we should choose smaller bore just to modify the calcification, and then we can use some other techniques to better treat the calcification.
Yeah.
So Dr. Gong, you put the first stent already, right?
Yeah. Next we will implant the second stent.
Mm-hmm.
The second stent is 4.0 and 28.
Did you prosect the circumflex?
Yes.
Ah, it's other way. You know, when we try to put the second stent, there will be overlap between these two stents. So the overlap zone should be a little bit away from the first diagonal, right?
Yes.
Just to decrease the risk of the occlusion of the first diagonal.
Just a little contrast. Not.
So Dr. Wang, are there any questions from the audience? Because Mainstream 360 creates a platform. You know, when the audience, when they watch the procedure, they can ask some questions at the same time. Because I heard the first case was very attractive. The audience had a lot of questions about the use of intelligent visualization of the coronary arteries and the use of different techniques to treat the calcification. So no new questions?
No new questions, but just like in the previous case, Dr. Cao Yang communicated with us the difference between the rota and the IVL. As we all know, IVL is a new weapon for us. So there's there's less article in IVL compared with the rota. So we can see as the previous article told us, after a rota and IVL, calcified plaque fractures with a much significantly greater number of fractures after IVL compared with RA. But the use of RA was associated with a greater acute lumen gain. As we all know, the rota had a debugging effect to the calcification of all kinds of plaques. But IVL just make some fractures of the calcification, but not the normal vessel or the lipid plaque. So if we want to if we want a larger acute lumen gain, we should choose the rota first. But Dr. Cao and me have tried a lot of have paid a lot of attention to the articles recently, but we cannot find that we cannot find the articles about which one is better for the minimal stent area after the stenting. So I think the further research should will tell us the results.
So both techniques, I think they have their own pros and cons. And sometimes for certain calcified lesions, maybe rota is the better choice. For some other types of lesions, the IVL is the better choice. And sometimes we have to combine these two techniques. So it really depends on the morphology of the lesion. So now we are doing AVAS after the stenting, right?
Yeah.
So Dr. Wang, can you take us through the AVAS image?
Okay, we can see the stent and the lumen now is acceptable, but we need some post dilator. And is this the first AVAS image after the stent?
Yes.
Oh, okay.
Okay.
Okay, I think Professor Gong should choose a bigger balloon to NC balloon to do the pot.
Yeah. According to the funding and the imaging, next we will perform a pouch technique with the 5.0 balloon at the left main stent. After we see the stent get well a position, but in some segment we will perform further post dilation to get optimal stent expansion. Okay, first we will perform the pouch technique. A little contrast. Okay. Okay. 12. 16.
So once we cross to the left mean because there's a difference in terms of diameter between the left mean and the proximal RED. So after the standing, we always have to do the plot in the distal left mean to get a better standing results.
Yeah. Slowly to 20.
But from the AVAS image, there's no like stand malposition, but only some parts is not well expanded.
A little contrast. Okay. 20.
So, Dr. Gong, as we all know, we have more and more provincial strategy in the in PCI nowadays. So it's much easier and have a good long term term outcomes. So when we do the pot technique, which position will you choose the first time you do the pot technique?
And for the first part, the
Okay, got it.
the distal mark of the NC balloon will cross the main branch, and it's very important for the next kissing technique. For the second part, we also know each named report. The distal marker of the NC balloon will locate at the distal the proximal of the bifurcation.
So after the first pulse, you will do the KBI. Even though the ostium of the circumflex looks relatively healthy.
Yeah. The post dilation and the KBI will also performed respectively.
So what's the balloon size for the circumflex?
For the circumflex, we will choose a 3.0 balloon. Okay. Okay. 16. We will later contact. Okay. Okay.
All right. So 2 minutes left, and then they will transfer to Nanjing.
Another will form. I will rewire.
So now you're trying to rewire the circumflex from the distal stem strut, right?
Yeah.
It's kind of hard to manipulate the wear.
The tape. Okay. Of the tape of the Y. Maybe need a reshift.
No, it's okay.
Assign branch. Okay. Okay.